I'm Amanda Deutsch. I'm the Director of Wellbeing at Thomas Jefferson University.
I'm Katrin Tyler. I'm the Medical Director for Physician Wellbeing at UC Davis in Sacramento.
My name is Casey Marone. I'm about to finish up my medical education fellowship at Thomas Jefferson University.
I'm Ish Chopra. I'm a faculty member at Jefferson, and I do not have a fancy title. I'm just here for the ride.
Hi, I'm Dan Bornbrenner. I'm an attending in emergency medicine at Thomas Jefferson University Hospital with these guys, and also an attending in palliative care too.
Ditto, except my name is Rita Manfredi, George Washington University, emergency medicine and hospice and palliative.
Good morning. I'm Susie Bentley. I'm the Chief Wellness Officer at New York City Health and Hospitals Elmhurst, and also one of the SIM people.
I'm Amanda Michelle Ritchie. I'm a fourth-year EM/IM at LSU in New Orleans.
I'm Andrew Wong. I'm at UC Davis. I'm a emergency department wellness champion, as well as a peer supporter and the medical director for managed care.
We have no financial disclosures. That's okay. I'll let you guys know what our objectives are. You can pretend it's up there. So hopefully by the end of this session, you'll be able to discuss the importance of acknowledging the emotional response that happens after an adverse event and really the need for having diffusion. We're also going to highlight the differences between, there's subtle differences between debriefing and diffusion and why we really are championing diffusion. We're going to demonstrate how to actually initiate diffusion. Sorry, the caffeine is just hitting the tongue right now. After an adverse effect, we are going to be discussing ways to develop a systematic approach to initiate diffusion after adverse events in your own emergency departments and sharing stories of how we have done so at our own institutions and hopefully getting some input from you guys as well if you've implemented something similar. And hopefully we'll just be able to kind of share lots of great ideas. I'm sure you guys have done some interesting things at your places or some of the different panelists up here. So, in our training and practice, we encounter cases that stick with us. Really, like the best case scenario is a patient says thank you, low bar in emergency medicine, or you have a great save, you have a great patient encounter. But more often what happens is there's a tragic, deeply emotional case that we have, and it really just sticks with us and often reverberates within us, especially when we encounter a similar case. They can interrupt our sleep, they replay in our heads, they can affect our self-insight and how we feel in our role as a physician, often make us second guess ourselves. And I know for me personally, I've had to spend time with some of the people on this panel sitting and talking through cases to really just get the insight of, hey, did I do something wrong? Am I a bad doctor, right? Even after doing this for a decade. So these cases really can affect us, and we very much feel that you need to have a space to start the process of feeling the emotions and understanding the trauma that we're encountering through these cases in order to process it fully. And we believe that part of that should start after the event, and then obviously continue on in your own way with what works for you. This is probably an obvious question, but has anyone here experienced that kind of case? Wish I could put two hands up and all toes. Yeah, I think I saw people nodding as I was, kind of discussing the feelings that I personally experienced with those things. I think it's par for the course in our career in this type of environment that we practice in.
Oh, yeah. So, I think Rachel Rahman, had this sort of magnificent quote that actually we use a lot at Davis in our peer support teaching, which is, you can, I'm just going to read the quote directly. The expectation that we can be immersed in suffering and lose and lost daily and not be touched by it is as unrealistic as expecting to be able to walk through water without getting wet. And, I think, one of the things that I've experienced is that there are some patients or families or experiences that you carry with you for decades. You know, I mean, I can, and I do think there's certainly a memory bump, you know, earlier in your training where you sort of first come across these things. But I just recently had one that has profoundly affected me, even though I've been doing this for a really long time now. You know, and I didn't even experience it. I mean, mine was sort of 2 steps removed from the primary event. So I think that, you know, we do a good job of sort of pushing this down so that we can get on with seeing the next patient, but eventually it catches up with us. And so thanks for being here.
So, you know, it's really important that we acknowledge that the reverberation of these really tough cases is due to what is known as vicarious trauma. You also have heard it called second victim syndrome. Anybody heard of that one? And these can occur with any adverse event, but I would like to invite you to not call them adverse events anymore. I'd like you to call them, because adverse has sort of a negative connotation to it, and there's more of a no connotation if you call it a critical incident. So I've changed my language. I no longer call these tough cases adverse events, especially if there's a poor outcome. I call them critical incidents. And so what are these things? Well, maybe it's an unexpected pediatric death, or maybe it's that person you were just taking care of, they had a precipitous decline. You were just talking to these people, and now you're not talking to them anymore. Or a colleague from the hospital who might have just gotten admitted to the hospital, or you witnessed some workplace violence. Or anything that might have happened to you. But research definitely shows that recurrent exposures to these kind of critical incidents really has a long-standing effect on you. So it affects your well-being, it affects your your clinical performance, and it affects one other really big thing that the C-suite's always looking at, and that's patient safety, okay? So, but these events continue to accumulate and accumulate and accumulate, and that's when we do start to see significant effects, negative effects on our own well-being, on our professional fulfillment, and that's when we feel this thing called moral injury.
So now I'm going to talk about debriefing and contrasting it with diffusing. So debriefing is a directed, intentional conversation that can be used for knowledge or skill attainment, or to answer questions about threats to patient safety and patient care based on a recent event or a hypothetical situation. So as you've probably maybe heard in Amanda's talk earlier today, research suggests that debriefing is a great way in order to reflect upon and analyze a clinical event, and has been shown to improve team communication, enhance learning from crisis incidents, and ultimately improve patient outcomes. Only rarely does debriefing cover wellness, and I do want to give a shout out for that talk earlier today, in which wellness was in that whole circle as part of something to be covered as part of debriefing. So in contrast, diffusing is a well-being practice that involves talking it out after an adverse event in medicine, providing a psychologically safe environment for emotional processing. So with diffusing, it's less about what happened and trying to come up with a solution, but it's trying to really give emotional support. And one of the things that also is in contrast is that commonly debriefing is used in the sense when there is an adverse event that happens, because all of us, we like to be able to look into negative things and be able to solve those issues. But diffusing, it can be used in any situation where there could be intense emotions experienced.
So for many of us, think about your critical incidents. There's probably codes, there are probably traumas, and that's what we're involved in And that those kinds of things benefit from debriefing. So there was a nurse by the name of Jonathan Bartels from the University of Virginia, who in 2009 sort of reintroduced the age-old practice of honoring and stopping everything at the moment that a patient dies. And this is what he said. At that point, I want us to be together and present in a singular moment of grief and loss. And he said this, after the code, after the event. I would ask each of you, in your own way, to offer silent recognition to the loss of human life. This was someone's mother, father, sibling, child, and to remember that that person was loved and had loved, and to understand that the person's passing deserved recognition, and also to acknowledge that our own efforts, too, were worthy of honor.
And what you're hearing us say earlier, there was a debriefing lecture led by Susie, which was amazing, and it was offering that the idea of diffusing is just a term, right? It can also be known as supportive debriefing, just wellness debriefing. We're just saying we need to start talking about the emotional sides of things to be able to even get to the clinical and quality improvement debriefing that we know helps patient care and isn't done enough. So I know a lot of terminology going on, but really amazing that we start to close those boundaries and make this understandable and important to be able to talk about the emotions.
So I just wanted to talk about that pause again, that Bartel I just told you about. So if you do a pause, that pause actually is going to slow your racing mind and offers a mental space so that we're not drawn into this vortex of saying, was this a success or was this a failure? This practice actually empowers each of us to offer support without imposing our beliefs on anybody else. And it's both communal and individual. And it allows for secular or religious and humanistic perspectives. And the pause also helps families. So you wouldn't think that's the case. And Bartels previously tweeted that when families see you stand and silently honor, it helps them too.
And so debriefing about our emotional response after an event is not systematically implemented. How many of you actually do this every time, or try to, I should say? Okay, awesome. More hands than I expected, which makes me really, really happy. Because we know it should be, right? To be able to talk through this, sometimes it's just acknowledging those moments and stopping for a second, whether it's the pause or even that next step that we're offering we do, which is the diffusing part. We need to actively work to facilitate and implement and build safe spaces and language for these moments after these critical events. Not only for ourselves and our colleagues that are in there with us, but our trainees, our nurses, everyone needs to see us doing this to acknowledge and keep us going, right? If we start to do this, I think it helps us all remember why we're doing this. And sadly, I had a recent even reminder of this. I was thinking back to residency when I was practicing in a very much gun and knife show. And we saw thoracotomies all the time. We were doing them, you would get it done, you leave. You don't think about it. And I remember my attending one time sent the med student to follow me. And afterwards I came out and I was talking to that attending again, and I was like, oh, did you talk to the med student that was following me around in there? Because it was like, drop off by the police, quickly did the thoracotomy, and there was nothing to do. So it was called. Very brief, very quick. Unfortunately, we're used to it. And he was like, oh, no, I didn't think about that. And I was like, well, aren't they only an MS3? They maybe have never even seen a death, let alone that is a very violent and quick way that almost looks like we don't care, how we quickly have to keep going and compartmentalizing. And so I'm always drawn back to, what does that do if we don't even acknowledge that for that one student, but let alone that we all deal with it, unfortunately, all the time?
And so while we're talking about things that may sound simple, it doesn't necessarily mean it's easy, right? Like for many, many years, discussing emotions did not have a place in the House of Medicine. This is not something that we have done. It's not something that a lot of people are comfortable doing. And I think that, unfortunately, that has been the culture that a lot of us have been raised in. Fortunately, I think we are in a position of leadership as physicians to start to help change that culture. But I think that ultimately that needs to happen by us setting the example and bringing other people along with us, opening that door to allow that to happen. I think it's only then that we can start to normalize these kinds of discussions and create a safe space for them to happen. Because we know that hanging on to this second victim syndrome or this vicarious trauma, it undoes us. It can seep into other areas of our lives. It can affect our practice, our burnout. And we need to be able to implement systematic, structured ways that we can mitigate those effects. And so I think that having the discussion about how we can use diffusing as a way to do that and as a path into debriefing to reach these clinical events that we do need to uncover in a lot of these cases is really, really important for us. And so, I know for myself personally, as I also think back to a case from residency, I had a really tough case in which, I had to intubate a patient, which I knew was going to go poorly. Those patients where it just seems like everything is kind of set up against you. And of course, it did go poorly. And eventually this patient ended up losing their pulse and we had to code them for a very long time. And that was very traumatic for me as I walked out of that room, feeling like I had taken actions that I was knowingly afraid of taking and that I felt like I had killed that patient, that was my fault. And thankfully, this was an end of a shift, so I didn't have to go directly back into patient care, which we do so often have to do. But in that moment, I think I wanted to reach out for that support and for that emotional processing, but I didn't know how, and my attendings weren't meeting me in the place that I wanted them to, and that was really hard. And I think those are things that played in my mind over and over again for days. And it took speaking with my co-residents, which I was very ashamed to do, to kind of start to process this, but it felt like it just needed to come out. And I expected them to, say, you're a bad doctor, yeah, you absolutely did something wrong. But of course the response was, I wouldn't have done everything different. That sounds really hard, kind of normalizing it and kind of just taking on taking the burden and the weight off of just because we have emotional responses to our patient care and to these critical incidents doesn't mean that we have done something wrong or that it is our fault, but that these are just normal parts of doing the really, really difficult job that we do. And so I hope that we can start to move towards a culture and a practice of being able to kind of express those emotions, process through them, and allow them to pave a way for productive clinical conversations as well.
I think one of the other things, I think we all have stories where we've, been seriously impacted by, a patient case, what have you. As EM, I spend half of my time on the IM service, the other half on EM. So I'd been in the ED probably 7 months cumulative at this point. And we had this 3-week-old who came in, unfortunately coding. And, EMS had worked them a long time. Everything was super pint-sized. We have our moment of silence, which thankfully we always do in New Orleans, and come out, we're on to the next patient case, and sit back at my desk for a second, and I look at the med student, and I'm like, you good? They're like, yep. I'm like, no. Are you good? You okay? And one of the things we talk about in, a lot of well-being is the double tap of being it's a social pleasantry of, hey, are you okay? And everyone's like, oh yeah, I'm totally fine. Yeah, you're not totally fine. So, just asking that second time can really give you a different answer, because the water work started and then I took them off into a back hallway and we had a chat. So, really important for that student to be like, no, it's okay. The emotions are okay. This was tough. Let's talk it out.
And if I can just build on that a little further, I think, and it was mentioned, as the physicians, I just want to point out and remind people how much power we have in role modeling also. So I can remember early on in EM residency thinking that I had completely chosen the wrong path, because everybody was witnessing death nonstop. We're in a busy trauma center and then going right back out to work. And I remember holding back tears after a pediatric case and wondering why no one was fazed by it. And it actually bothered me no one was fazed by it, but I figured I would get that shell, that protection would develop. And then one day I saw one of, everyone has the scary attending. I saw the scary attending cry. in the hallway. And I was like, holy shit, it is not me. Like, she's crying. And in that moment, I was given such permission to realize that everybody was just strong facing it and bottling it up. And I think that's how we've gotten in this epidemic of burnout and people leaving medicine. So I am like the loudest person in every room talking about the emotions, even if I'm actually not even that affected, because you realize like that permission that you gave the med student will stay with them forever to realize they're not the only one. And I think that can never, that power is so, so important. And we really, are in a place to offer people to that. I think that's how we get the culture change in the House of Medicine.
I think I'm now supposed to talk about sort of timing and logistics of how we do this. But actually, since we have a little bit of time, I sort of want to poll the audience a little bit and ask you, what's your understanding of that sort of spectrum of diffusion to debriefing to sort of peer support, and what's the sort of time course that looks like for you, and what have you done that's been great, and what's been, I mean, I've done these and they've not been awesome sometimes, so.
And me and one of the pharmacists there just released a paper on second victim syndrome. And we took a survey for nurses, everyone that works in the emergency department, doctors, faculty versus non-faculty, because faculty is all cancer and the non-faculty does community emergency medicine. And we also looked at how to solve this. And I love everything you guys have said, it's amazing. But I'm wondering specifically exactly what you're asking, because I think as a teacher, we need to realize when we debrief or defuse that group, every person that we're speaking to is different and has a different way of processing and coping. And they may be, emergency medicine is a rigid field. You're expected to be tough. And it may not be very easy to turn that tough person off in 2 seconds. They have 72 other things they're doing, and if they do break down then and there, they might fear they're not going to be able to carry on with their duties. So I think by recognizing that everyone has a different timing, I think the data that we've collected, the sooner you get to people, the better, but you shouldn't see it if there's 10 people there and we feel like we got to 6 of them and we didn't get to the other 4 of them, if we could potentially do it, try to get to the other 4 of them later. Because, I don't know, like I said, the research we show, out of all the remedies for this, meeting with your department head or having a safe space, a quiet space to go rest or having a few hours off, all those options, it seems like debriefing, and you guys have enhanced that, diffusing the situation is by far going to have the best impact on everyone there.
Great. Anyone else have any thoughts? You don't have to have published a paper on this.
I really, so I'm a, oh.
No. Yeah.
I'm good, okay. I'm Justin Bruton. I'm an EM palliative care doc. I'm a stairwell crier and a car ride home crier, and I'm married to a therapist. So most of my emotional intelligence I've obtained from her. But I really appreciated what you were all saying about how we need to model this and we have to change the culture. And I hope I don't upset, this is hard when you hear people talk about things because it can remind you of other things. One of the toughest cases we ever had at one of my shops was it was an adolescent suicide. And one of the things, that was one of the few times I did a formal debrief, and one of our chaplains came in, and I think it was really helpful. And one of the things I wanted to try to do was just let the staff know this is you're gonna have a ton of emotions, that's normal, that's important, you need to process this stuff, and just kind of validate it. As the leader of the team, I'm definitely not a therapist, but I feel like you said, the permission thing was really big. And one of our, the effects of this are longstanding. So of course this happened right before I hear your talk. I had one of the staff members that was there that day that had to leave early because she's like, I gotta go see my kids. She still works in our hospital, but she never came back to the ED after that. And I had her, I took care of her I took care of her kid as a patient, like it was some minor thing. But I saw her literally like maybe 2 or 3 weeks ago, and I'm like, I recognize you. And she's like, yeah, I used to be down here. And I was like, and it clicked, and I'm like, you were there that day, you know? And the other thing is, one of our nurse managers said to me, and this is one of those things as a physician, I think for all of you are obviously very on top of this. She's like, I'm really glad you were there that day. Because that is like, we really can set the tone. If as awful as these things are, we can't necessarily make them better, but we could definitely make them worse. So when you have that awareness, like you're really giving your staff a gift to help them process that. And it's not gonna make it go away, but it definitely sets a different tone than if somebody was there that day that was just didn't have the wherewithal to make those decisions. So this is great panel, really appreciate what you're doing.
I think it's also a good showcase on the different types of debriefing you're able to do, where you can do a hot debrief. Some situations are not going to be feasible for that. We had the terrorist attack on New Year's Eve in New Orleans. A hot debrief when we didn't even know what was happening was not going to work. We just knew that we were in an MCI and shit was hitting the fan, and didn't even know it was a terrorist attack at that point. And then a couple hours later, it's like, oh my God, this is happening in our city. So then there's also the warm debrief, which happens, 24 or 48 hours after. And then you can do a cold debrief, where it's been, 5 days, 7 days, when you get everyone back together, part of the shift work, but be like, let's talk this out, where, instead of, one and done, and everyone goes their separate way and no one checks in on them, that's just another opportunity to check in, make sure that everyone's good, do some action items of, hey, this is what we learned and what we can do better, but this is also what we did really well.
Yeah, I mean, the only thing I want to add to that is I think just taking like my palliative informed care that often comes into the ED in like indirect and direct ways. It's an iterative process for this, and it's not just the modeling once in a specific geographic location, but it also occurs in time as well as in space. And I think just being present with people and acknowledging that this is a terrible situation and centering the humanity of the whole experience there, not just of the patients who had to experience it and their families, but also the providers and the multidisciplinary teams, like that's a worthy thing to do, even if you don't know what the right words are or what next steps are necessarily going to be. Perfect is the enemy of the good, and I think just intuitively, providing that space for people now and letting them understand that in the future it's okay to talk about these things. Like that's part of this process too.
I think the other thing I wanted to just add is that it just starts with one thing, right? So I think we're giving you a lot of, like Amanda said, data points and specific terminology, and hopefully you walk away with a structured approach to this. But, we are also traumatized in that moment. We are also running an emergency department and responsible for the emotional well-being of our residents and our other staff members. And there's an asshole in the waiting room that needs to be kicked out, and a family member that's upset. They're like, Mima hasn't gotten water while you're like, watching someone die. All that situation that we deal with, right? And for me, I struggled as I became an attending to figure out how, I have a lot of training in simulation and debriefing, so doing something like a plus delta or like a structured model was much easier than figuring out how to bridge that piece of how do I bring wellness into this. And for me, it was just the first thing I started doing was just saying, that was really hard for me. And like, as the person in the room that's supposed to be the leader and the person that's supposed to be setting the example, saying, you know what, that was really hard. I'm having a lot of emotions right now. And even if no one else wanted to add something in that moment, you could look around the room and see people nodding and acknowledging like, yeah, that was really hard for me too. So, again, while we're hoping you walk away with like more structured tools, even if the one thing you take away is just add one thing to your next debrief or one thing to your next conversation after a difficult situation, even if it's just acknowledging your own emotion. Like Susie was saying, right? Like, I'm the scary attending, but I'm also at my shop. But I'm also, I'm the first person to say, like, I can't believe that. That was hard. Oh, Susie. I'm great. I'm great outside of work, but but I'm also the first person to like say, hey, that was really hard. I think the other thing, also echoing what a lot have been said, remembering the power you have. So I have sent residents home, right? Like, I have the capability as an attending to like handle this emergency department. And if I'm seeing that a resident or medical student's not doing well, like we had an unfortunate case where we coded an anesthesia resident, and one of his co-residents was my off-service intern that day. And he tried to continue to work, and I said, absolutely not, you're going home. Like, you can't, right? So I think sometimes just taking that power into your hands and realizing, like, no, you know, like right this moment, I don't have to go through the administrative channels and call Jeopardy and all that. Like, no, I have to recognize that someone in front of me is not doing well and just send them home and embrace that power. And then, you know, I'm a do first and ask for forgiveness later kind of gal. So, yeah, you know, just own your power and then just start with something, one thing.
I don't think I have anything as impactful as Isha said. And Susie, she is the scary attending. I know it's hard to believe. But I think it's also important to acknowledge, even though we're up here talking about this, it's really hard to make the space to do this still. And so, again, I agree. Like, we're trying to just give you some framework to figure out what'll work in your shop, for your peeps, because it's just important. I don't always have the ability to do this either, because sometimes it just hits me too hard. But it's having that moment to pause, even if it's not a death, right? Even if it's just that workplace violence, and trying to call that out, label it, and say, that was really hard for me to even just watch, right? It's unfortunately not usually happening to us. But to like create these spaces so that we start to normalize and give back the humanity to us so that we can stay in emergency medicine and not all of us leave, or else SAM will be very sad too. But truly, right, how do we help ourselves?
I just want to amplify a couple of the points I heard from what was shared from the audience too. I think it's important to remember that this is the start of the conversation, but not the whole conversation. So I love what you offered the team and how powerful that was. And I'm glad you're working that day too of that case, right? Although I'm sure you carry a lot of that with you. But this is creating the space and the culture that this is what we do. We talk about how much stuff sucks when people die and when things go south, or when someone reminds you of your partner, your mom, and maybe there's a great outcome, but you still, whatever you take away from that you internalize and carry, and it has to be plugged into, you know, a bigger approach to things. So do you have peer support? Do you have resources? You know, the hill I'm going to die on is, because I do a lot of debriefing for quality and safety and wellness, is you have to end with resources. Because if you end 100% of cases, good, bad, and everything in between, with medicine's really hard and it really, you know, everything hits differently. Here are the resources. You can reach out. You said people often don't want to take down the shield because there's the asshole in the waiting room, right? That's okay, but just normalizing that someone is there to talk to, or reminding people just that they need to talk to someone, is really, really powerful. COVID was a really salient example of that. I run our huge peer support program for the health system, and we weren't gonna go start asking people how they were doing. Like on shift in the department when everybody was dying everywhere, right? That was not what people needed. They needed to know resources were there for 2 a.m. or noon whenever they took a break. Then after. So a lot of it's discretion too. But I think, like you said, you have to start somewhere. And the culture change is acknowledging that I don't have the answer either, but I'm just here to sit in the shit with you, because it is really hard and it's really sad, whatever the emotion is. And a lot of people shy away from that conversation because they don't, quote, know the right thing to say. They're worried what happens when someone starts crying. Like, then you call peer support for them, or you just hand them a tissue. And you say, I don't even know what to say. God, this sucks sometimes. I've been there, right? You don't say I understand. You don't say at least, right? All those things, but like you can just say you don't know what to say. And stay and not be scared of whatever emotion they're sitting with. And again, role model it. So you don't have to have the answers, and we don't either, although we talk a lot, as I always do. But it's about starting somewhere. And again, the culture change starts with all of us, just bringing a little bit of the humanity there and being vulnerable. And then that's what hopefully will catch fire. And that's how we're going to keep doing EM for hopefully lots and lots of time after this.
So I'm just going to bring us back to the logistics and timing sort of conversation that I bombed. But I think also just sometimes we can overcomplicate this. Sometimes it's important just to let the team go to the cafeteria, right? And take a really mini break just to sort of put a before and after. And I sort of think that the bigger the tragedy, the more time and space we need, understanding that that's often really challenging in a very busy emergency department. But sometimes we're just witness to people's normal tragedies, and That probably doesn't require quite as much time, but still requires a pause. And so, I find it's actually really helpful to just have people go get their lunch and then come back, and then we just have a little talk about it while people are eating. And you put a little break and a little sort of boundary around what you're doing. Obviously, if it's a bigger event, then you need more time and space. But we sometimes overcomplicate it, I think, and just like acknowledging what we witnessed is important.
So I'm curious, we've heard a little bit. Would others share how have you incorporated defusing into your clinical practice? What does that look like for you?
It can be the good or bad if it's not gone well.
Yeah?
So I have one that it nearly went badly recently. So this was actually a fire captain, and they were doing their routine training, and the fire captain collapsed in a VFib arrest, right? And so they were on a training exercise. So he's surrounded by 50 other fire department staff. So he got excellent CPR from the very get-go, but was essentially still, never got anything close to a ROSC. It was a pretty hot day. They'd worked on him for a long time by the time he arrived in the emergency department, and we were unable to resuscitate him. Andrew's probably experienced this. We have our nurses set up this sort of pathway that doesn't always work very well, where you try and combine a evaluation with a debrief. And in this particular case, we're sitting in a pretty small room with 10 burly fire department staff, very emotional, feeling like they failed. And one of our husks starts reading off this list, and I'm like, we're not doing that. We're just here to talk about how we feel. But I was grateful that I had enough experience to be like, we're not going down this path. And it's sometimes hard to stop that train. So I guess, I would just offer that if it doesn't feel right, it's okay to sort of stop it and re-divert it.
So I don't have a formalized process for incorporating diffusing yet, but I'm a nocturnist, so my time is usually divided and less structured during daytime shifts, but I try to incorporate little pieces into the actual diffusion time, because the reality is I would love to have the space to have like a large debrief and diffusion, but that's not the reality. Sometimes when I'm the only attending there, or I just don't have the capacity. But so try to incorporate or acknowledge my emotions during a debrief. I pause for the moment of silence and allow people to have their emotions and give the space. But something I try to also do is I find every person that was involved in the critical incident afterwards, and I touch them if they're okay with it, put a hand on the shoulder, I say, thank you. Are you doing okay? I'm here if you want to talk about it, either now or later, and I either provide my cell phone number or my email or something like that for people to reach out. And honestly, that usually happens after the more upsetting, tragic cases, and I would love to do it more consistently, and I'm aiming to, but at least in those cases, I make it known to everyone that I appreciated their time and effort, acknowledge the difficult situation, and then, provide time to kind of do a cold debrief or diffusion later if possible. I think just trying to incorporate little pieces into your day as opposed to thinking about it as this is the defined time to do it has helped me to bring more of the emotional space into, the shift and the time longitudinally after the event as people are processing their emotions. So I think that's something that I've tried to incorporate to kind of do almost like micro diffusions after the event as kind of we go on through the shift, and even later on, like checking in with people like on a subsequent shift or like with my residents through cell phone or email.
I have an example from residency that was kind of the germinating experience for me that was not something afforded by my own department, I think because of time and resource limitations. But I took sign out from a team that did a resuscitative hysterotomy on a woman who was killed by her ex-spouse while actually taking gifts from her trunk during the baby shower. He shot her several times, and she came into our emergency department, and they did the resuscitative hysterotomy. They coded both her and the neonate unsuccessfully, and they had a planned debrief after, hosted by the Department of Obstetrics and Gynecology, that the only people who attended were me because I was a rising chief and my department chair, and no one else could go because we were all working so much. And it was really impactful to see that the OB-GYNs, they gave the resident who performed the actual resuscitative hysterotomy, I think a couple weeks off. It was such a negative experience, but they just let them sit there in silence, and people were crying. It was really hard to see that, but it was also hard to realize we didn't actually have that kind of capability ourselves. And I've really kept that in the back of my mind for a long time. But like Isha said, I think what's helpful is if you're not getting quantity, you're getting quality with the people who have been impacted by this experience. And I really am a firm believer that if you get 5 minutes, make them 5 good minutes. And so just being present with people as much as possible. I mean, this is all intuitive, but it's still good to reaffirm, just checking in, asking how you're doing, and knowing that your team, you are available to your team. I have had debriefs, actually technical debriefs, where we have to find a space for it, and they start going long because people are talking about important details, but it sometimes gets tangential, and that can be awkward when you have to go back to the rest of the department. But just making yourself available in a longitudinal capacity, I think, is really important for people to know that you're there. And just one more nod to the fact that we do work in a multidisciplinary environment, and I think that I love emergency medicine because it's a team sport, but people look to the physicians as a model for many ways and reasons, and I think it's important that we are there in a demonstrative capacity, not just a purely professional and performative one. So, anyway.
I'd just like to highlight, I'm here as a resident. It doesn't matter how new you are. You're never too new to help someone. And, if someone else isn't doing it, take the onus, because if not you, then who?
I know we've all shared, and it's kind of similar of how we try to create the space. Has there been anything differently that anyone has done that you guys want to share before we talk about some systematic changes we can try to do?
Before we move on to that, if no one in the audience is going to say anything, just one little thing I'd like to mention, and that is know who you're sending home. Okay? Because you could have another critical incident if that person is not supported. So please be careful about just saying, go home, rest, because you don't want something else more serious to happen.
Yeah, I would say going home, whereas it might be a wonderful thing, it can be very dangerous. I think
Absolutely.
speaking to the person as much as you can, 20, 30 minutes if you perhaps have time, and getting someone else to speak to the person, that will not only help you address it, but you also identify, making sure this person's not a danger to themselves. The person who actually, I'm texting now, who helped me co-write this article, almost killed herself because her event was so strong. I wasn't there when this happened, it was 20 years ago, but she was at that point. She didn't want to go on. So I know it's a rarity, but and going home might be a good thing, but it also might be dangerous, like you said.
And don't make assumptions about, who they're going home to, because you might think of your own situation, and maybe there's very safe listeners and support at home, but, especially residents, if they're by themselves, they've moved to new cities, people are vulnerable for lots of different reasons. So they may be going home to stare at a blank wall and have no one. So they're much better off, staying. But that can be, a joint decision about what they need. But I like that point. I think it's very important. We have lots of people that don't want to go home, and outside of EM departments that have tried to mandate residents having to leave after a death in the OR, different things. And the residents have said that is absolutely not helpful. So
That's why we've been looking at the quiet space more. That's what a lot of our providers answered they wanted to have after this happened, just a place to go, whether it's 10 minutes, an hour, or
yeah.
two. And then what you were saying about, you're a resident, like I've been practicing what feels like a million years, and I feel like I probably have a degree of PTSD because I never addressed this for years and years and years. And we, if we can move forward with this, like look at this at like
We all
how
do.
it does, follow people. Like you're addressing this so wonderfully early, like you'll probably be a success story and be able to help so many people in the decades to come. I would think.
Here's our
whereas-
hope.
But part of that is like how our society has progressed, like and how doctors are trained. Like maybe when they were trained in the 70s and 80s, they were taught you're not allowed to behave like that. We don't care about you, we care about the patient. So that's.
Oh, I think the culture has made that loudly apparent in the past, definitely.
But Epi,
Yeah, I would say I don't often send residents home. I've done it a couple of times, but I am a great believer in the break, and not just when there has been a severe event or something that could potentially be very stressful, but just like to eat and I like mom our residents hard and make them go like actually leave the department and eat for 15 minutes every shift. And part of that is that I learned that it's fine when I had children and I was pumping for a year and a half for each kid that like I could disappear from the department for 20 to 30 minutes, 2 or 3 times a shift, and absolutely nothing happened. Nobody died. I looked, they sent us our metrics, our patients per hour and time to doctor. My metrics didn't change. Like, actually, it was just equally efficient. Everything was exactly the same when I disappeared for 30 minutes. So when I can do that routinely, multiple times a shift, you bet a resident who's just experienced a traumatic event can go and just take a buddy, you can send 2 of them, and sit in the lounge and have a coffee or a glass of water and just be absent for 20 to 30 minutes because like, I've run my own numbers. It doesn't actually make you worse. It's all the same. So they can take a break.
And always remember that the ED is connected to a ramp where the ambulances come in. That's usually connected to the outside. That's where I send my residents. Go outside. I want you to look at the sky, I tell them. I know that sounds stupid, but look at the sky and I want you to breathe in the air and don't come back until you do that.
I just wanted to add, I think a lot of what we're describing, these are reactive strategies, and I think this is deliberately a reactive strategy, but ultimately the hope should be to transition to a prophylactic milieu where we can have enough awareness of what's going on that we build these processes into the fabric of our department and also just build these like traits, culturally en masse so that we can start checking in with people who are affected by these before it really becomes like a malignancy, like an emotional malignancy. And that's, I think, what my collaborators are trying to get with, and I think all of us are trying to hope for, is that we can start really nipping this in the bud before it becomes something that just tears everything apart.
I love it. I think as we transition to our last minute or two and then give space if people have questions, the pause, obviously we've talked about the moment of silence. You can call it either or, but I think so important to have, and I love that this was added because what we can do is give people the ability to have the words there, right? If you create a badge buddy, even just for the pause. Or when I was a fellow at Stanford, what we did is we created a 4-prong system because why would we do just one thing? But if you can see, step 1 is taking that moment of silence or having the pause. And then we ask that people actually created 5 to 10 minutes they would try to diffuse. And we did this with trauma and emergency department so that specifically after traumatic deaths, to have a starting place that we hoped it would go to every type of death. And then we did do an email out within 72 hours so that we could say, we know you were part of the team, whether you were the tech, the pharmacist, the social worker, the med student, everyone got that email, which took a lot of effort from the trauma team to really find everyone, which I loved, so that we could really acknowledge that again. And then we even did a once a month healing session on Zoom that you could just go to, not even if you were part of that case, but it was just open if you wanted to be led by grief counselors. So this was one systematic change that was done. And I really loved that, and I hope we can all start to do that. And why a lot of us are up here is we're gonna give a badge buddy to really give this to our department soon so that residents, nursing, everyone feels like they have the words to start to do this, because I think part of it is just the inertia. It feels scary, but we can make this easier for everyone to be supportive. A lot of questions, yes?
Just a quick question. I see that
Yeah.
was a 6-month pilot.
Yeah.
Was it sustainable at Stanford, or did it die at the end of the 6 months? Or did pieces of it stay sustainable, but, prong 3 and 4
Yeah.
were not feasible, or,
Great question. One thing you can see, there's a gift card that was in step 3 that was thought of really negatively, that we were rewarding deaths. So that that part went away pretty quickly. And I'm no longer there, so I don't know how often they continue to do this. But I really hope they at least continue a moment of silence. But yeah, it's a great question. Yeah. I left. I'm at Jefferson now. Yes.
Can you comment on, or if any of you know, has like ABEM incorporated any of this into the body of acceptable knowledge that residents need to master as well to take care of themselves or anything?
I can answer that. So there's a couple of us working on, Kei Uichi is working on this from Mass General. He's actually doing the questions for the new serious illness discussion that you're supposed to have as part of your oral boards. And then they also have me, I'm learning how to do this, working on actually implementing this type of thing into the written exam. So having a case like this and saying, what's the first thing you do after, and so we can, even if people get the answer wrong, that will happen. And so that's what ABEM is doing. So it's really helping us because it's inserting it into what people are going to be tested on. Did you have anything to add, Tish? Because do you know any more about that?
Just that I thank Rita and Kay for having that voice on the ABEM, question writing committee, because otherwise it could easily be overlooked. So thank you.
And if you haven't figured out, most of us like to talk, that we're happy to come talk to your residents and start to really normalize this, because I think that's where it starts too. My colleagues know I try to talk to them, the residents, a lot to be like, let's talk about this. But right, each space matters, because sometimes they want to hear about it, other times they think, sure guys, let me just do what I need to do and get out of conference or whatever they want to do. Any other questions? Thank you. I know last day of SAEM afternoon is not a fun time. We thank you.